friends. So in this video we'll be having our discussion on the abdominal surgical conditions in pregnancy, specifically your appendicitis and gallstones. So these are some of the integrated questions that come from your surgery and gynae mix. So let's discuss few important MCQ points regarding your appendicitis in surgery. So please remember, this appendicitis in surgery is your most common extrauterine acute abdominal condition in pregnancy. Now, it is common in which trimester? It is much more common in your second trimester. Now, the classical obstetric teaching states that the cecum and the appendix is pushed to the RUQ, that is right upper quadrant, as pregnancy develops during your second or third trimester. Now, here the question arises, what is your most cardinal feature of appendicitis in pregnancy? So, is it the pain in your right upper quadrant? No, my dear friends. The answer is pain in right lower quadrant. So, even though that the cecum and the appendix is pushed towards your right upper quadrant, the cardinal feature of appendicitis in pregnancy is your pain in right lower quadrant. Now, regarding your diagnosis, it is very essential that you have a diagnosis of appendicitis. So, for that we need an ultrasound and a MRI. We don't do CT scan for obvious reasons, as they have radiation hazards. Now, regarding sensitivity, MRI is definitively more sensitive than your USG. Now, why this pre-op diagnosis is important? Because if you have a negative appendectomy, what is going to happen? The fetal loss rates are approximately 4% and preterm labor rates are approximately 10%. Right. So, it is very important that you make a diagnosis of appendicitis. Now, coming down to the treatment part, in acute appendicitis, the fetal loss rates varies from 3 to 5%. However, the important point to remember is that it is going to increase to more than 20% if there is an appendiceal perforation. So, because of this particular fact, the non-operative management of appendicitis is not recommended and surgery is preferred. Right. So, this is a very important point that you need to remember in case of appendicitis in pregnancy. Now, which brings us down to the next question, is laparoscopy safe? If so, in which trimesters? So, as per the recent edition of your Bailey and Love, the answer is yes. And when it can be done? Laparoscopy can be done in all trimesters. Right. So, this were your few important points with respect to your appendicitis in pregnancy. Right. Now, let's move down to the next topic, which is your gallstones in pregnancy. Now, the most important points that you need to remember in gallstones in pregnancy, the first question is that it is your second most common non-obstetric indication for surgery in pregnant women. So, which is the most common? The one which we discussed before, that is your acute appendicitis. Now, what are your risk factors? So, we have pre-pregnancy obesity, right? Then we have multiparity, then increasing age, and genetic predisposition. So, these are some of your important risk factors for your gallstone in pregnancy. Now, why does this gallstone form? Now, because of the hormonal effect. So, what happens is that estrogen increases your cholesterol secretion and progesterone decreases your bile acid secretion. as a result of which the bile becomes super saturated with cholesterol. Apart from this, progesterone also slows your gallbladder emptying. Now, because of which bile stasis occur, and this further promotes to your gallstone formation. Now, what are your differential diagnosis of your acute right upper quadrant or your epigastric pain? Now, what are your this differential diagnosis of your acute cholecystitis in pregnancy? So, first and foremost, we have your severe preeclampsia and HELP syndrome. Now, I'm pretty sure you guys must have read this in your gynae, but still I'll just write down the full form of the HELP syndrome, which is H for hemolysis, EL is your elevated liver enzymes, and then you have your LP, which is your low platelet count, right? Then your other differential diagnoses include acute fatty liver, then we have your abruptio placentae, then we have your uterine rupture, or it also could be a intra amniotic infection. Now, what would be your our investigation modalities? It would be a USG and a non-contrast MRI scan. Right. Now, regarding your treatment. Now, in the first trimester, the mainstay of your mild cases is mainly your conservative treatment. NSAIDs are usually effective, but they are avoided, and that too especially after 32 weeks. Why? Because it causes your premature closure of patent ductus arteriosus. You guys must have read this in your pediatrics, right? Why? The answer is premature closure of PDA. Now, in case of second trimester with moderate or severe disease and patients who are generally good surgical candidates, what do we do is a cholecystectomy. Now, this is done during an initial hospitalization. Why? Because it causes a high risk of recurrence or serious complications subsequently. Now, in case of your third trimester, we give the patient fluids or your antibiotic therapy. Right. Now, such patients are generally re-evaluated after delivery. So, what is your waiting period? It is usually your 6 weeks, which gives sufficient time for the mother to recover, and then the further treatment plan can be carried out. So, this were your two important abdominal surgical conditions in pregnancy. The first being, the most common being your appendicitis, and second being your gallstones in pregnancy. Right. So, important points that you need to remember in your appendicitis is cardinal feature is in pain in your right lower quadrant. Then your laparoscopy is safe in all trimester. In case of gallstones in pregnancy, it is your second most common. The various risk factors, which include your pre-pregnancy obesity, multiparity, increasing age, genetic predisposition, the cause being your hormonal factors, then your differential diagnosis, which includes your severe preeclampsia and HELP syndrome, acute fatty liver, abruptio placentae, uterine rupture, intraamniotic infections, investigations being your USG and non-contrast MRI. Then the treatment in first trimester mainly being conservative. NSAIDs are avoided because it causes the premature closure of your PD, and that too specifically after your 32 weeks. If it is in second trimester, there are high chances of complications in the subsequent period. So cholecystectomy is usually done in your initial hospitalization, and your third trimester you would generally manage it with fluids and antibiotic therapy and reevaluate after the delivery, and the waiting period is usually 6 weeks. So this were your few important abdominal surgical conditions in pregnancy which are very important for your INI exam. So keep revising. All the best.